start there. It's an autoimmune condition, right? Where the body attacks its own pancreatic beta cells. This leads to an absolute insulin deficiency.
Exactly. And these beta cells are essentially responsible for producing insulin. The immune system, triggered by genetic predisposition and often environmental factors like viral infections, initiates this destruction. It's a fascinating and complex interaction.
Right. Which is why diagnosis isn't just about identifying high blood sugar. Testing for autoantibodies, like the islet cell or anti-insulin ones, is absolutely crucial.
Precisely. And when we talk symptoms, there's often a dramatic presentation. Things like polydipsia, polyuria, and even weight loss. In fact, many patients experience diabetic ketoacidosis at the initial stage, which can be life-threatening if not managed promptly with insulin therapy.
Absolutely. Okay, now let's shift to type 2 diabetes, which honestly is a completely different beast. It's not only an immune system issue this time. Instead, we're talking about insulin resistance and eventually beta cell dysfunction.
Right, and that's where lifestyle factors like obesity and physical inactivity play a role. The cells in the liver, muscle, and adipose tissue become less responsive to insulin. So the pancreas tries to compensate by producing more of it. But over time, those beta cells wear out.
Yeah. And then the blood glucose levels start creeping up. First post-meal, then fasting levels. Classic signs of progression. What blows my mind, though, is the options we now have for managing this. Like metformin. It's kinda the star of the show, isn't it?
Indeed. Its action is to reduce glucose production in the liver and improve insulin sensitivity in peripheral tissues without causing hypoglycemia, if I might add. But more recently, drugs like GLP-1 receptor agonists and SGLT2 inhibitors have shifted the landscape.
Oh yes, those. GLP-1 receptor agonists, for example, mimic that incretin hormone from the gut. They regulate insulin and glucagon secretion. And SGLT2 inhibitors? They work by simply getting the kidneys to excrete excess glucose. So smart.
And yet, we can't ignore the challenges here. Patients might struggle with side effects, especially gastrointestinal disturbances from metformin or the increased risk of urinary tract infections with SGLT2 inhibitors. Personalised treatment is critical.
Right? Plus cost and adherence. I've heard of so many cases where the lack of affordability or the complexity of a regimen makes sticking to it really tough for patients. But innovations in weight management drugs, that's a game changer alongside glucose control.
No doubt. Throw in lifestyle interventions and we've got a very holistic approach evolving. Yet tailoring these to individual needs is no small feat. Maintaining a balance between efficacy and comfort is an ongoing process for clinicians.
Totally. And speaking of balance, thyroid disorders really show how important it is to keep those hormones in check. Exactly. And thyroid hormones are such a prime example. When they're out of sync, it's not just your metabolism that takes a hit, it's nearly every system in the body. Let's dive into hypothyroidism to start. Hashimoto's thyroiditis is the leading culprit, isn't it?
That's correct. Hashimoto's is an autoimmune disorder where the body's immune system, for reasons not entirely understood, begins attacking the thyroid gland. This leads to reduced production of thyroid hormones, mainly T4 and T3. And globally, we still see iodine deficiency playing a role in hypothyroidism too.
Iodine deficiency. It's so basic, yet it can have profound effects. But for Hashimoto's, and really hypothyroidism in general, the go-to treatment is levothyroxine, right? A synthetic version of T4?
Exactly. Levothyroxine effectively replaces the deficient thyroid hormone, and the goal is to adjust dosages until TSH levels normalize. You also want patients to experience relief from symptoms like fatigue, weight gain, and cold intolerance.
But Ethan, Adherence here is everything, isn't it? I mean, taking levothyroxine at the same time each morning on an empty stomach. It's it's kind of strict, but it makes all the difference.
Absolutely. And patients need to avoid certain foods or supplements for a few hours, like calcium or antacids, because they can interfere with absorption. Educating them on this is critical to success.
Now on to hyperthyroidism, like Graves' disease. It's like the thyroid on overdrive, isn't it? Excessive production of T3 and T4 can cause anxiety, weight loss, and oh, those heart palpitations. Thrilling to diagnose, but whew, tricky to manage.
Right, and Graves is also autoimmune, but in the opposite direction. The body produces these antibodies that mimic TSH, called thyroid stimulating immunoglobulins. They trick the thyroid into overproducing hormones. And you're spot on. It's a systemic condition that can even lead to ophthalmopathy in some cases.
Oh, I love the depth of it. But most commonly, we manage it with carbimazole. Yeah?
That's right. Carbimazole inhibits thyroid hormone synthesis, effectively helping to reduce those runaway levels of T3 and T4. But here's the kicker: hyperthyroidism can be challenging to sustain in remission. Relapses are fairly common.
Especially for some patients who might end up needing radioactive iodine or, in extreme cases, surgery, right? And those acute cases of thyroid storm, wow, they demand immediate critical care.
They do indeed. A thyroid storm is a hypermetabolic state, life threatening if untreated. It demands interventions like beta blockers, antithyroid drugs, and sometimes steroids. Thankfully, it's rare.
So, bringing in both hypothyroidism and hyperthyroidism, doesn't it just scream how vital education is? Patients need to know their meds, dosing timing, and oh, keeping up with lab checks like TSH and free T4.
Exactly. Visual aids can be a game changer here, like flowcharts to show the feedback loop of the hypothalamic pituitary thyroid axis. Simple tools like this can make a huge difference in patient understanding and adherence.
Totally. It's one of those areas where a little knowledge shared with patients can empower them significantly and in turn make clinical management way more effective. Ethan, speaking of how vital endocrine balance is, from thyroid to other glands, let's pivot now to the adrenal glands. These are such key players in our stress response and metabolism. Should we start with Addison's disease? This one's all about cortisol deficiency, right?
Absolutely. Addison's disease is characterized by insufficient cortisol and sometimes aldosterone, often because of autoimmune destruction of the adrenal cortex. And managing these cases hinges on hormone replacement therapy with hydrocortisone or fludrocortisone to restore balance.
Right? But what really stands out to me is the importance of emergency protocols. Patients with Addison's disease must carry around emergency injectable hydrocortisone for adrenal crises. It can literally save lives.
Precisely. An adrenal crisis can occur in the context of severe stress or illness. Without intervention, the lack of cortisol can lead to life-threatening hypertension and shock. Education here is paramount.
And on the flip side, we've got Cushing's syndrome, chronic exposure to excess glucocorticoids. Whether it's endogenous or iatrogenic, the therapy involves tapering down steroids or even surgery for cases like a pituitary adenoma, yeah?
That's correct. And monitoring is just as critical. Patients must be checked for signs of adrenal insufficiency during tapering. It's a fine line between managing cortisol excess and avoiding a deficiency.
Definitely no easy fix there. Now, let's move to bones. Osteoporosis is a big one, and bisphosphonates are kind of front and center for treatment, right?
Yes, exactly. Bisphosphonates, like alendronate, work by inhibiting osteoclast activity, which reduces bone resorption and enhances bone mineral density. They've become a cornerstone in managing osteoporosis to minimize fracture risk.
Oh, and what about teriparatide? That one's super interesting because it actually builds new bone. Perfect for severe osteoporosis cases.
Totally. Teriparatide stimulates osteoblast activity, creating stronger, healthier bone architecture. But it's often reserved for those who haven't responded to first-line therapies. And then there are selective estrogen receptor modulators, or SERMs, like raloxifene, providing an alternative approach, especially in postmenopausal women.
Ah, SERMs. They're fascinating too, mimicking estrogen in bones while avoiding other tissues. The options keep evolving, but combining these interventions with tools like fracture risk assessments, that's the next level of patient care.
Absolutely. Tools like FRAX allow us to individualize care by predicting fracture risks and guiding decisions. And don't forget, effective polypharmacy management is crucial, especially in elderly patients juggling multiple endocrine conditions.
Exactly. Teaching patients about adherence and side effect management can make or break therapeutic success. It's our role to align treatment plans with their lifestyles and support systems.
Couldn't have said it better. With the right approach, we're not just treating bones or hormones, we're improving lives. And that's what makes this work so rewarding.
Totally. And on that note, we've covered a lot today, from diabetes to thyroid, adrenal, and even metabolic bone diseases. Such a pleasure unpacking it all with you, Ethan. And to our listeners, thank you for joining us.
Yes, thank you. Stay curious, stay informed, and we'll see you next time. Take care, everyone.